Do you want to get started? He wants to ask a question, so.
Okay, everyone, so we're going to get started. This session is about provider payment mechanisms. But before that, we just have one question from the audience, and then we'll move into a role play, followed by a presentation and discussion.
Thank you. So my question is regarding the cost effectiveness, like the previous, regarding the previous session. So I'm not a health expert, but the natural logic would say that if we treat cost effectiveness as a bank per bag concept, like we want to save as much as possible per $1 spent, then again the natural logic will tell me that we want to make some research, find out what are the most impoverishing diseases that could be prevented in advance, and then include all the prevention measures in the package, and basically we'll end up with a corner solution, like include all the maybe I'm telling something stupid, but then my guess is like you need to include all the preventive measures in the package, and then all these preventive measures, because the general concept is that it's always cheaper to prevent diseases than to cure them afterwards. So then maybe we just include all the curative measures, and then we will end up with the decrease of further diseases, and then we will save much more money and don't spend them to cure all these diseases.
So great point. So cost effectiveness analysis is definitely used in many countries, but then even so there's trade-offs. So we need to think about, yes, the future costs averted and maybe the budget impact, because maybe there's technology, so there's preventive technologies that are very expensive and maybe do it more cheaply. But yes, I think that is definitely one, but not the only criteria. Ajay, do you want to?
So, believe it or not, there are actually some conditions where it's more cost effective to let the person get sick and treat them than to prevent. But by and large, yes, that is the case. That's why you don't only want to use cost effectiveness criteria. So you want to also look at whether or not something is, where the criteria may be different related to financial protection. So some examples were given where the conditions are not necessarily cost effective to treat, but they will prevent financial protection. So there are some attempts to try and bring in the financial protection dimension as well. And you can also weight them by equity. So there's a lot of literature out there. Even WHO actually has a recommended package at the primary health care. So there's a lot of, it's not something that you need to start from scratch. There's actually what is it called? The disease control, do you want to talk a little bit about that? It's a massive, go ahead. No, it's a massive research project, right?
That's ideal. In reality, what happens is that these decisions are also political. And, the package comes out of, you start scratching your head and wondering where did this come from, probably some interest group and stuff like that. So bear in mind that it's not just technical, but I think it was a great question.
Respond to that with a more concrete example, perhaps. Let's take ischemic heart disease. Stents have already come up as part of the basic benefit package. And Armenia has a problem. It's prevalence is high, and even the fact that the people are talking so much about interventionist cardiology is an illustration that this is in people's mind, because it happens in families, in populations you hear. But then from a public health and purchaser perspective, so how can I deal best with the problem? As a Minister of Health, I would argue for some of the actions that doesn't cost money, perhaps some political capital, that the outside sector, like tobacco taxation. Because we know many Armenian men smoke, so how can you reduce this? Then move to the healthcare and say, well, how is the most cost-effective way for me to deal with this problem. And I would include some of the primary prevention for sure, not secondary prevention, I would call it secondary prevention, meaning find the patients who are at risk. It costs some money at some activity. You ask primary healthcare to do something, manage their early conditions well so that they never get to the complications that requires stenting. So you get more value for money, more health, and reduce the number of stents you need to put at some point. But that is to me like, from a benefit package and policymaker and purchaser point of view, is like, okay, that's the way, and I can go to these disease priorities and look at evidence-based literature, so figure out so much effective. Drugs came up. I would include drugs that help to manage this chronic conditions best, look at best value for drugs as well, include them in the benefit package. So to me, that is more pragmatic approach, how to...
Okay, we had one other question.
First of all, I would like to thank Rose for this interesting presentation. Really, it was very useful. And we understood once more that our healthcare system is very, very complicated and fragmented. But I would like to raise one problem in this stuff. We saw that we have many, many programs which provide free or with co-payments access for both primary and secondary healthcare services, either for the whole population or for some target groups. But meanwhile, we know that we have such a catastrophic number of out-of-pocket payments. And the reason for this also is that a big part of those out-of-pocket payments are informal ones. That means that even in case if some healthcare services are free, but people used to give under-table payments to doctors. And I think that that's a very essential and very important problem that we have to solve. And unless we solve these problems, we cannot provide an effective working new program for the population. Thank you.
Excellent point. And I don't know, Rose, if you want to say anything. I think on the first day we talked about national health accounts, and there was a question about whether or not informal payments were included in that. And my understanding and for the discussion with the woman who's in charge of national health accounts, where is she, Rose? Yeah, is that it is, but it's very interesting to talk about. You're already getting into the diagnostic tree and the root causes of this. So unless you're actually addressing the root causes of those gifts and the payments, and it's part of the culture. But yesterday, Ian talked about incentives. What are those underlying incentives that are keeping that culture in place? And yes?
Here's what I suggest. There are a lot of very interesting questions coming up. And in order to save the time and let people now provide the payment mechanism, what I suggest is if you could write some of these key questions down, we would love to hear from you these questions. And then after afternoon session and before your group work, I suggest we have like a half an hour questions and answers so that we can directly answer to specific question from you. We can have a discussion, we can have whatever it takes. You know, you will bring your coffee in before you start the group work. We spend half an hour answering to this question. Very interesting points that you all made, and I'm really grateful to both presenters and you as audience that this engagement is happening. That's why we are here for. All right? So why don't we start with...
I'm extremely busy. I am the head of the State Health Agency. So I am the State Health Agency, and I have a big task. I'm extremely frustrated because the health outcomes in my country are just not very good. Utilization of health services is just completely low. I don't know what's going on, and I really need to find a way to fix this. I think my country's finally able to move from input-based to output-based payment, and I'm thinking that I really need to think, now which payment mechanism should I be using? Now, I remember attending the flagship course with the World Bank. It was in Washington. It was, 10 years ago, but I was really long, and I think the session on provider payment was in the afternoon after lunch. I was exhausted. I think I might even fell asleep, but I remember them talking about, okay, if I want to incentivize use of services, I should use fee for service. So I think, Tomas, this year we're going to try something new, okay? We're going to try, I want to pay you, you're going to sign a contract and you're going to pay, I'm going to pay you fee for service. And I really hope that this is going to help increase utilization, okay? So Tomas, are you okay with this? Can you please sign this contract?
Make a crying sound. So they see the health problem in the background.
So what does it mean? That means like when I provide a service, I get paid?
Exactly.
Of course, I sign any contract that would tell me that.
And I really hope, I know you've been having trouble attracting patients. I really hope this is going to help you get those patients through the door.
We are open.
Make it. Hello. Are you
Hello.
Dr. Palu?
Yes.
Oh, let me get that.
Can I run a test on you?
Sure.
Okay.
Why not?
I take a quick blood drop and send it to the lab.
Don't you want to hear my problems first? I have many, many problems.
Perhaps I send you to X-ray before?
That sounds
when
wonderful.
Was the last? Okay.
And I like injections also.
Okay.
Yeah.
Okay.
And medicine, some medicine.
Okay.
I like taking pills.
Got prescribed.
Right.
What was your problem?
So where do I begin? So one is, shortness of breath. I was walking from walking up over there. I was coughing and slight pain in the chest. And I thought, why not come and see my favorite doctor?
Okay. Let me see.
But that's just the start of the problems, Dr. Palu. Yes. I have many, many others. I have anxiety, sometimes difficulty sleeping at night.
Okay. Okay.
And I get very stressed when people ask questions in lectures.
Okay.
Do you have like Xanax for that?
Well, we have perfect drugs. They just came to the market. My good friend is actually bringing them to the market. I can prescribe you the best drugs. Let me quickly check.
Is it the drug they use in the
Yes,
US?
that's the
Because
new
I've
drug.
heard American drugs are very expensive and very good.
But the health
I don't want
insurance-
generic ones.
Health insurance covers them, so no, don't worry.
Don't worry.
And I have an excellent psychiatrist that will take a look. I will send you immediately. It's a good friend of me too. And I believe he has a contract with health insurance as well, so don't worry.
No, I'm not worried. While I'm here, Tomas, I also have this ringing in my ear.
But
It happened 3 or 4 months ago.
I can see that you couldn't stand. I think
Yes.
you may have some hip problems or knee problems. I can have an orthopedician, so they can look at maybe you need a hip replacement. We do that. So,
Only the best ones, though, because, I only go to the best.
Done. Okay.
What about the ringing in the ears?
Well,
Do you want to do a test?
yes. Bing! No, that's too cheap. I will send you to, we have a great audio lab, so we test you the frequencies you can hear. But I see you really can't stand, and we just included in the benefit package the very well-coated stents. And I think you may have some looking at a little bit that you are overweight too, so
I'm trying to lose weight though.
Problem. So maybe as a preventive measure, we just do invasive angiography and then put the stent so that you can be sure you never have an infarction.
No, I've heard
measure.
prevention is always more cost effective than cure, so let's do it.
So
Yes,
I'm so
thank you.
excited.
So,
I'm looking at my electronic information system and I'm seeing, wow.
Well, I send you the pills, okay?
Oh, yeah.
It's the
Actually, why not
one,
2
it's the
stents?
Doctor?
Only one is covered. I can pay out of pocket.
So I see utilization seems to be going up. I think we might be okay now. It seems a little high, but that's what we wanted. We wanted to increase utilization. It's been pretty low. Okay, I'll just give it a little bit longer, maybe a few more months. I hope Dr. Palu seems to be attracting more patients.
Dr. Palu,
Yes?
I just gave birth. And
Excellent.
you
We
know,
love children.
Oh, my
We
child.
can vaccinate them.
Please no. No, I read that in one village in Agveran that a whole village got sick because of measles. So no, don't touch my kid. Just focus on me. But by the way, my husband is a farmer, but we did not make the cutoff of family benefit package. We didn't make the 30 score. So please no out of pocket for me. I am not part of state order, but I know that antenatal care and postnatal care is covered by state order. But then also I have depression. I think I cannot take care of the baby. And then I couldn't breastfeed. Like, I read in the internet that I need maybe I have breast cancer maybe because milk is not coming out. But I think it's covered by the benefit package because it's maternal program, right?
You have Googled well. Breast cancer.
Yes.
Yes, we know.
Yes,
It's a big growing problem in Armenia, and we just got this perfect three-dimensional mammogram.
I want MRI. Mammogram is painful. If possible, MRI, okay?
But you said you're not covered by the package, right?
Yeah, but this is maternal program. It says it's
Oh,
for
it is covered,
everyone.
of course. So mammogram, three-dimensional, the MRI, got it. We can do PET scan as well if you want. We have this one as well. I prescribe you some drugs for your anxiety. And Gavi still was paying over vaccines. We still vaccinate your children 2 times over. We need to get numbers up, yes.
Maybe next year
No, we do it today because it's well covered. It's included in basic benefit package. Don't worry, that's yes. Well, yes, you should trust the doctor. You should trust the doctor, yes.
But my husband said no.
And please come back tomorrow.
And my mother-in-law
You are a very
said
good
no.
patient, and I will also, with your depression, I sent to the same psychiatrist I sent the previous patient. They can take really good care for you.
Okay, thank you very much. Thank you.
So, Dr. Palu, I finally had time to catch up with my claims payments, and you've done a good job, and particularly with maternal and child health, I see increased utilization of immunization, and I know that a lot of mothers also have postpartum depression and anxiety, so I think it's fine that you prescribed many drugs for those women, but, you had a doctor, I was looking at my audit, you had a patient named Tandon. Do you remember that visit?
Tandonyan.
Now, my audit has told me that he came in with ringing in his ear, and he left with prescriptions for stents and all of these 20 other services.
Are you a medical doctor?
What's going on
Are
here?
you a medical doctor?
What is going on here? No, but I am paying
How
for the
can you
healthcare
say
system.
that you prescribe anything to the medical
I have
doctor?
evidence. I have my information system. I know about clinical
But
protocols.
You know maybe you have statistics, but you haven't seen the individual patient. I have taken the Hippocratic oath when I said I do everything I can.
Is
that
this
can
just a
benefit the
business for you?
patient.
This is just about business?
No,
Don't you
no,
have
come on.
underlying incentives to help
Death
your country?
panels,
And
death panels.
this is, we're going to have to do something different, Dr. Palu. This year, we are moving to capitation payment. So for
is that?
every patient on your list,
Oh.
I will give you a
I need
fixed
to
fee.
take a note.
Okay?
Okay. Capitation, that's what it's called?
Capitation, yes.
Okay.
So you get
it's like a headache, capita, Latin.
you get a
Let's
fixed
say
fixed
the tip.
amount for
Okay,
every
okay,
patient on
capitation.
your list.
Speaking of headache,
And you
I'm
get-
back, Dr. Palu, your favorite
You
patient.
get 20,000 drum.
Well, this patient looks like overweight,
Headache,
old.
ringing in the other ear now.
We are closed right now. We can't take you on. Sorry.
So, but I can't give a lecture if I have ringing in my ear.
Oh.
No?
Zero Narchik.
no.
Zero Narchik.
So,
You seem to be. What's your
Dr.
name?
Palu, Dr. Palu.
Dr. Palu, what
What's
about
your
my depression? What about my depression?
She looks healthy. She's running. How can I get her to my list? Do you want to join? Come to my list. Because you never come to.
We are dying here and you're running after the healthy.
How about my baby and
Sorry?
my depression? My depression and
Ringing
the
in
baby.
both ears now.
Okay. Well, ping. Do you hear that?
No?
You know, half a tablet of aspirin a day would do good for you.
That's it?
Yes. Yes,
What about the other ear?
Well,
Yeah.
I don't know whether my capitation includes referrals as well. Well, no, really.
My
no.
anxiety, her depression.
What about
You are doing
my
well.
baby?
Eat better, yes. Sleep better. You're doing. No need for
Doctor.
medication.
What is this?
I'm still sad. What about my depression?
Who's your husband?
He's in the farm.
Well, you know, talk to your husband. He can
He's very busy.
lighten you up. I have this half a tablet of aspirin I can give to you. The other I just gave to him.
Are you trying to save money?
My aspirin.
What about
too.
our health? You want to share the aspirin? I can give you a quarter.
No,
Okay.
the issue is that I want a little bit. We need to put air conditioning to our
Are you
ambulatory.
part
so
of
I need
the-
to save some money from capitation?
They were talking about death panels on CNN. Are you one of the members of the death panel?
Maybe next week.
You're killing us.
Yeah,
You know that.
Okay.
Dr. Palu, what is happening to my health outcomes? They've gone way, way down.
Really?
And even Gavi and Global Fund are wondering what's going on. No, we're no longer in the MDG, we're moving to SDG, but we still have to focus on those targets. And what's happening?
Well, somehow,
You're not
people
doing any screening, you're not doing any immunizations anymore.
Really?
What's happening? No.
Okay. Yeah. Well.
And the health outcomes have gone way down.
Yes. Well,
know-
but I get this lump sum payment, so I can decide what I do with them and what I don't do, and so
I
why
think
should I do
we've got to
these
change your
things?
payment mechanism again this
Again?
year. We're going
Okay.
to something new. It's a very new mechanism. It's not one of these traditional mechanisms.
Okay.
It's
Tell
going to
me.
solve all our
I need
problems.
to take notes.
It's called capitation plus pay for performance. So you're going to have a fixed amount. It's going to be similar to what you've had this year. You have the opportunity to earn 50% of your capitation
That's good. We love. Yes, we need.
for
We need
achieving
new windows too. So yes.
certain health indicators,
Okay.
their outputs, so on the way to health outcomes.
Okay.
So we want to see more screenings,
So what is before?
we want to
what
see
I need
higher
to do?
immunization coverage.
Immunization. Oh! I
We want-
remember I had this woman with a child. Where is she? I just. Oh,
You said I should.
how is your child doing?
My ear ringing. No?
What's this part of the performance? Ear ringing?
Screening of early detection of hypertension. We
Oh, yeah.
Yes. Can I get screened?
Yes. Come here.
Come.
So I measure your blood pressure. Are you husband and wife, by the way?
We could be. Since we're sharing medicine already. you know. That's the first step.
Yeah, you have a high blood pressure, so I prescribe you some drugs so
Okay.
that you can keep it under control.
Thank you so much.
And
You
what
saved my
about the
life.
booster of my when I come?
Yes, well, you get it today. Yes.
Okay.
You know, this seems to be going well. I think actually, we've got a pretty good balance. Our budget is doing pretty well. And we seem to have increased health outcomes. I think this results-based financing is really the way to go. Maybe we should try this for the TB program. What do you think? Because right now, the TB program, all those doctors, they're keeping those TB patients in the hospitals forever. They're so long. We just keep paying and paying and paying these per diem payments. And it's related to length of stay. So maybe we should try this, maybe we should incentivize the communities and get them to really manage TB care. What do you think about that? Would you be open to managing TB care?
Well, I need help with diagnosis and some advice from specialists, but on ongoing basis, I would love to do it. But I know it's politically very difficult to do because it's been long time done different ways in Armenia, in other countries. So how to make this change to facilitate this will be difficult, but it needs to be done.
Well, I think if we work together, and maybe we can get some help from the donors too, we can really come up with an effective way to design provider payment mechanisms that help our whole system. We have to get out of this way of thinking just one service. We have to think about the whole system.
And I do some screening too. I know this Ajay Tandanyan who came to my office. He had some cough. So I will check that whether it's TB or not.
Great. Thanks for a great year, Dr. Palu.
All right. So thanks to Dr. Palu. He actually is really a medical doctor. and to Rose. So as an introduction to the provider payment mechanism session. This session is basically the first part of the session. We'll sort of set the stage and understand the language of provider payment mechanisms. What do we mean by provider payment mechanisms? We'll just do a quick group exercise in terms of understanding what the incentives and structure of different provider payment mechanisms are. And then Sarah will give some examples, real-world examples of what is happening globally in some of the countries, what some countries are trying to do in order to tweak the provider payment mechanisms in order to get intended outcomes. So there were some terms used during the simulation, so we just want to make sure in the first part of I don't want to have that, to understand it, make sure everybody's on the same page. And where's the clicker for my, it's over there. Yeah. So just want to make the link to the overall flagship framework. So we are now talking about the second control knob, that of payment, and as the terminology suggests, we're trying to see, are there things that we can do in terms of how we pay providers that can help us get at the intermediate and final outcomes. Are you following me so I can be on the camera? No. So like I said, in the flagship framework, they are using this as a separate control knob, but typically both of these are included in the framework of what is health financing. So health financing is not only about how you raise revenues and how much revenues you raise and how you pool risks, but also about how you pay providers. And the goal here is to try and pay providers in ways that will improve the efficiency and equity of your resources. And so the rest of the session, let's just go through the language and the landscape of provider payment mechanisms, some of which were already mentioned in the simulation. So the first session today talked about the benefit package design. That included what services were included that are going to be paid for by prepaid pool services versus out-of-pocket. We talked about explicit and implicit benefit packages. What should be included? How should those be expanded? What's the role of cost effectiveness? What's the role of equity considerations or financial protection considerations in deciding what goes into the benefits package? So now we're going to talk about how are you going to pay the providers in order to deliver the benefits package, in a sense. So this is the second part of the benefits, the realization of the benefits package. And also you may want to include this in the discussion as to who will provide the services. So not just how the services will be provided, how will they be paid for, but who are you paying these to provide these services. So these choices are there in all health financing systems, all health systems, as to how you end up paying for services that are included in the benefits package. A couple of key points to keep in mind as you listen to this lecture is that how providers are paid is a key policy lever. It's a key control knob that can impact health system performance. You may be able to use it to improve quality, to improve efficiency, to improve equity of outcomes. The one point is that as you're listening to me, I need for you to think like you're economists, not like you're medical doctors. So in order to understand some of the financial and other incentives included in provider payment mechanisms, we really need to think as though we are economists. So because there are incentives created in how you pay providers, and a lot of it is also about who bears financial risk. And we'll come back to this point as we go through the different provider payment mechanisms. So the way providers are paid can create different incentives that can have a very powerful influence in terms of, as you saw in the simulation as well, in terms of how providers behave and how they can help you attain your policy objectives. And also one point to make as I'm talking, it's not just how you pay providers, it's also how much you pay providers, right? So you can tweak how you pay providers as much as possible, but also the levels at which you're paying providers also matter, something that's often forgotten. So it's also how much you're paying them, not just how. And Sarah, you want to also make a point on transitions?
than countries that are transitioning from development assistance are also at the same time going through health reforms that may include shifts in the provider payment. So it's rare that you would think just about provider payment for those specific services, but it's really as the whole benefits package. You need to be thinking, okay, how can I also make sure that my provider payment for primary care may have these, will also incentivize immunization, or how can I better manage my TB program? Can I use the provider payment as a lever? So these can be one lever, one very powerful way of changing the incentives for providers.
So during the simulation, what did you hear? What types of provider payment mechanisms did you hear? Assuming you were paying attention to what Tomas and Sarah were doing and not so focused on the patient, me and Rose. So what were some provider payment mechanisms that you heard mentioned during the simulation? The simulation, there were some provider payment mechanisms. Did you raise your hand? Capitation was one. Pay for performance. Which is the other one? Fee for service was mentioned. There was one more. Fee for service. There was one more that Sarah mentioned. There was per diem, I think you mentioned, right? Per day. So basically, just want to make sure everybody is on the same page. So this is the universe of the different types of provider payment mechanisms that's out there. And together we'll go through to try and understand what is it from a financing point of view that is implied when you pick a certain provider payment mechanism. And typically the universe of what are traditional provider payment mechanisms comprises of these 6 categories. I'm using the term traditional here because there'll be a session later on where we'll talk about some innovative provider payment mechanisms that have been experimented with and are being introduced globally. So we'll set that aside and call those sort of the new provider payment mechanisms. But these traditional ones that have been used and are being used to improve quality, efficiency, responsiveness, and equity, we're going to do them separately, but just keep in mind that rarely do providers get paid using only one type of provider payment mechanisms. Typically, there are a combination depending on how your health system is organized. The 6 are line item budgets, global budgets, fee for service, capitation, per diem payments, and case-based. So together, we'll go through a bit of an exercise to make sure we understand what this really means. So let me and Sarah do the first one, and then we'll together do the other 5. So let's look at line item budgets. Does anybody know what a line item budget is as a way to pay providers? I think this was something that was discussed in the PFM session yesterday. So what is a line item budget mechanism of paying providers? What does that mean? How are you paying providers if you're using a line item budget model? Any volunteers? Do you have line item budget in Arminia? Have you heard of the line item budget? Yeah, so what is the line item budget? To you?
We have different lines in our budget, fixed.
So, yeah, go ahead.
We have defined lines in our budget for what purposes and how much is going to be spent on the specific line.
So can you give one example of a specific line?
For example, for drugs for TB.
Okay. So drugs for TB, salaries.
Salaries, yes.
Equipment, right?
Yes.
So typically line item budgets, providers receive a fixed amount of resources for a certain period, say for a year typically, to cover specific input expenses. Typically, these are input expenses, so you don't pay providers necessarily based on outputs or outcomes. It's inputs like drugs, salaries, equipment. There are some examples: maintenance to provide hopefully a stipulated set of health services. And in many countries, do you have line item budgets in Armenia? line item. So typically many times we see payment to public facilities by the ministry is done through line item budgets. So there are three attributes that we're going to focus on we are going to focus on for the remainder of the sort of this definition session. So we're going to ask whether or not providers are being paid based on volume of services that are being utilized. So under this system, is the provider being paid higher if there's more use by patients? The second point is, once the patient is seeking the service, is there a bundled payment for that service, or is the provider being paid for the amount of services? Again, think back to the simulation exercise that we did. Was the provider being paid based on how many patients they see? For each patient, are they being paid for how many services that particular patient utilized? And then who bears the financial risk? Is it the payer? Is it Sarah who bears the financial risk, or is it the provider? And by financial risk, I basically mean that if, for instance, utilization of services by the patients or utilization per patient of services ends up being much higher than expected, who bears that cost? So these are three attributes that we'll use to look at the landscape of different provider payment mechanisms. So maybe
I'll give you one example.
Yeah.
So a country I've been working in, Nigeria, they use line item budgeting, and so providers get paid, so salaries are paid, and there's many healthcare workers, and they see 2 patients a day, but they still get paid. Actually, many of them get paid if they don't come to work. So the incentive is not really there. Now, there's also, I think Srini talked about this flexibility. So that's not always the case with underutilization. Sometimes you have very high utilization with a line item payment, and maybe you need to shift your needs, but the line item budgeting, maybe you can't move from one line item to another. So there's pros and cons of these different approaches.
So in a line item budget, typically, again, we're being very reductive, we're taking the pure form of line item. The facilities are not paid based on volume in a given year. So it's not that they get more if there's more utilization of services. Also, typically, because this is input-based financing, they're also not paid more per episode of utilization. So regardless of how many people they see or how many services each person sees, there's no link in how you're paying the provider usually, and typically in the sort of the pure form of line item budget, the provider does not bear financial risk. So if utilization is higher than expected, or if for each utilization the services used are higher than what might be expected, what might the providers do when they're being paid line item? So what happens if, for instance, utilization rates are much higher than budgeted? So typically in a pure form, they just said, well, we were paid based on inputs. Go ahead and pay out of pocket or do something. So typically there is no financial risk borne by the provider in a line item payment model. So let's go through these attributes for the other 5, but just to make the point that Sarah was making, that why might some countries actually use line item budgeting? So typically the arguments that are given is that it's very useful when the provider may not have managerial capacity, you have strong administrative control, you're saying this is for salaries, this is for drug, so you as a payer are able to control your costs. So some weaknesses, as Sarah has already mentioned, is there's an incentive to expand input use as opposed to outputs because you're getting paid based on inputs. Sarah was making the point that you may actually end up hiring more doctors or paying for them regardless of whether or not they're adding any value. There's an incentive to under-provide services. There's an incentive to refer to other levels of care, and an inefficient use of resources because of rigidities that you may not be able to shift resources from one line item to the other. It takes away some of the options to move things around. And some design factors to mitigate these weaknesses is you may have stronger gatekeeping, penalties for unnecessary referrals. You could do add-on payments for quality control, and you may actually do performance-based budgeting. So, there are some strengths, some weaknesses, some possible ways in which you may want to mitigate these challenges faced with line item budgeting. And when we come to some of the country examples, we'd like to ask you as to what have you tried to do in order to mitigate some of the challenges that are related with line item budgeting. But let's do the global budget. So how many of you, is the global budget there in Armenia? Do you use global budget? So what is the global budget as a way of paying providers? Let's think of the pure form of the global budget just to make sure we all understand what this is. What is a global budget? Do you have a mic? Yeah.
Thank you. I know we are behind the schedule and I don't want to take up much time, but I think there are a couple of important clarifications to be made. Health service delivery is not financed by line item budget in Armenia since 1999. We have moved away from that old system after establishment of the state health agency, and as we all know, currently in Armenia both outpatient and inpatient care providers are financed based on their output. What our colleague was referring about programmatic budgeting. Our budget has program lines, but providers are paid according to the volume of services they provide. Now coming back to the global budget exists as a concept in Armenia, but it is implemented as a budget ceiling, budget cap, rather than total amount per year within the which.
So just want to make sure everybody understands what the global budget is. So what is a global budget?
Global budget, when a facility is given an annual budget for providing services, and they should fit into this budget, they are not paid after that according to the volume of services they provide.
Exactly.
So whether they provide more services or less services, they will get the same budget.
And how is it different from the line item budget that we talked about?
The line item budget provides certain amount per each economic category, for salaries, for utility costs, for drugs, and they cannot move funds if they have savings from one budget line to other budget line. They are not supposed to, at least.
Exactly.
But within a global budget, the management of the facility has much more flexibility, and they can manage their budget in a way they see it more appropriate.
So just making sure everybody understands the concept of the global budget. As he pointed out, it is basically a fixed capped transfer of funds to the facilities. You have flexibility in order to move items within the global budget around. But in terms of our three criteria, is it linked to utilization? And maybe let me ask somebody else. I know you've already. Is it linked to utilization of services typically, conceptually, when you're thinking about the global budget? It's not typically linked in any given year to how much services are being used. Is it linked to how many services per episode of utilization, typically? No. So, and then who bears the financial risk in the global budget situation? Again, we're thinking like economists, financing people. Who bears the financial risk? Who bears the financial risk? Remember, financial risk is when utilization, either in terms of numbers or utilization per episode, ends up being higher than you might expect. Who bears the risk? It's the facility. The provider here bears the financial risk, right? So here it's independent of volume. Payment is not linked to actual utilization. The payment is bundled, it's not linked to actual services used per episode of utilization, and provider bears the financial risk. So already you're seeing that one way in which you can, as a purchasing agency or as a payer, trying to protect yourself is to introduce what is also called sometimes the closed-ended payment system. So you're saying, I'm giving you the budget, global budget, I'm pushing all the financial risk on you. If something is higher or lower than expected, that's your problem. I'm protected from the financial risk, you take the risk. So of course, in the process of setting the global budget, you may have negotiations to make sure you mitigate some of those issues, but the principle is that. So what might be one of the strengths of the global budget? Why might you choose to do a global budget? So you may want to do because of input-related flexibility. Also, it's more predictable for you as a payer. It's also administratively much simpler. You don't have to worry about defining how much drugs, how much salaries, and so on and so forth. So that's one of the reasons, sometimes this is considered. It's relatively straightforward to administer. There's an incentive for providers to reduce unnecessary utilization because then the provider doesn't want to waste their resources. And also to reduce the provision of unnecessary services. There's predictability in expenditure, and like somebody mentioned, compared to line item budget, the providers have more flexibility and autonomy to allocate resources. Some weaknesses, there is still an incentive in a global budget to underprovide. So if you can, either you can limit, so if you can actually choose to ration care to patients because it's all coming out of that fixed global budget. So sometimes there is this incentive for underprovision. You may end up rationing services, or you end up having financial arrears if the global budget is not enough. And there may be incentives to prioritize urgent or acute care over chronic care and preventive services because you're really looking at it in a more reactive sense. So what might you try to do in order to improve or mitigate some of the weaknesses of the global budget? So by the way, do you use global budget? And you said in principle there's some sort of a ceiling, right? So what might you do to make sure, if you were going to give a global budget to a hospital or a facility, to mitigate some of the problems? What do you really care about? So here are some examples of what you can do. You can have stronger gatekeeping to avoid, pushing people out from using your services. You may have penalties for unnecessary referrals. You can actually monitor and hold the providers accountable for quality-related metrics. So this is a very important aspect of implementing a global budget. Typically, you don't only implement the global budget. You say, I'm going to give you a global budget, but I'm also going to be holding you accountable for some quality metrics to make sure there is no skimping of care by the provider. And you can also have adjustments over time made to the global budget based on volume of services.
Sorry, one question. So in reality, how do you implement these penalties for unnecessary referrals? I mean, how do you detect that this referral is unnecessary, this one is necessary, etc.?
So let's ask the doctors in the room. How would you do that? So first of all, everybody understands why you may want to refer away from you if you're being paid by global budget, right? So what penalties might you implement?
Referrals and the justification are usually provided in the guidelines. So the guidelines for a particular health condition, in the guidelines there is no indication for example, referring from the primary health care to the hospital, because the main basis are the clinical guidelines. Based on the clinical guidelines, it is decided whether they should be referred. So the indications for referral are indicated in the standards and the clinical guidelines. So if from the primary health level, for a particular health condition is recommended for the hospital care, this means that this is not justified or undue referral.
Clearly specified as to what are the conditions under which referrals might happen. Yeah, go ahead. Sarah, do you want to give him the mic?
Just a comment. But then we do not reduce the referrals. But basically, if a patient refers to the hospital, you need to check and then say, okay, I'm not giving you a direction to the hospital because your problem is not in our direction list, is not in our practitioner's guide, etc. But then, first of all, you need to check up this person. So this is also, this kind of guidance cannot reduce the referrals. They can reduce the afterwards redirections of these patients to hospitals, but the referrals themselves, I mean, how they can...
I think the issue is about necessary referrals versus unnecessary referrals. So that you want to make sure you're reducing unnecessary referrals that might be occurring because the provider is trying to make money. So if there are necessary referrals, of course, that's to be expected, and that's to be negotiated maybe in the next year if you're getting much more need to provide those services. So it's trying to reduce things that where it should have been provided at that particular facility, but you're pushing them off because that goes into your global budget.
So, Ajay, maybe we could just look at the circle and ask which ones are covered in Arminia, because I don't think we have time to go through, but we have the packets for people to take away and refer to. So maybe we can just select here. So in Arminia, do we have fee-for-service? Do we have capitation?
Any fee-for-service? Do we have fee-for-service in Arminia? Yes? So fee-for-service is one of the opposites of the line item budget in that your payment to the provider is completely dependent on how much utilization that happens. And if you have fee-for-service also for every service that gets used, it's also linked to the volume of or the intensity of usage. So it's one of those mechanisms which is called it's like an open-ended payment mechanism, so that here there is no limit put on in terms of what the providers get paid. So who bears the financial risk here in a fee-for-service payment? So it's actually that's a very good point. So in some cases when you're paying out of pocket, the payer is the patient, right? So some of it will be it will be borne by the patient, whereas if you're the agency or the payer that's paying fee-for-service, in that case the financial risk is borne by that agency. The point here is the provider doesn't then bear the financial risk. And one of the key problems with the fee-for-service method of payment is that you end up having, as you saw with Tumas's case, you end up having over-utilization, over-testing, unnecessary care, very easy in a health setting because there's a lot of asymmetric information. The doctor knows much more about the problem than the patient, so that information asymmetry, what economists call, can be exploited.
So Ajay, what could I have done differently in the purchase, when I was the payer of the social health agency, what could I do differently to still keep the fee-for-service?
So Sarah, this is the point where you don't ask me the questions, you ask the audience the question. So what could you have done differently in order to mitigate some of the problems that you saw with Tumas treating me with fee-for-service? There was an incentive, built-in incentive to over-treat, to over-provide. What might you do to mitigate the consequences of that?
Without changing the payment mechanism.
What could you do under a fee-for-service? I think he kind of already has answered a little bit. So one way, of course, is you combine a fee-for-service with a global budget, right? Many countries do that. You might put a cap, say, okay, go for it, go do fee-for-service, but after a certain limit, I'm going to not pay anymore. So that sort of, you try to control the financial risk that, the incentive to over-provide that the provider has. What else could you do? You might do case management. You may audit it before paying to see whether or not it was really necessary, and I think that was also mentioned during the simulation. So these are some examples that of situations that countries have done, and I think I have a couple of, let's just go to this slide. So you could have prior authorization and review for appropriateness of care. You might have additional incentives to keep volume and expenditure under control. You may track carefully what is the expected volume and services, and you could have expenditure caps. So this is often used in conjunction with fee-for-service, but typically fee-for-service is an open-ended payment model, and it's not advised to use that as a provider payment mechanism, except where you may have under-provision services. So where might you actually use fee-for-service? Where might you think there could be under-provision of services, and then you actually want to incentivize providers? Exactly. So that for some services, you actually may want to provide us fee-for-service. system. We'll talk a little bit more about that in the third session today, where we talk about some examples of countries where they've actually used fee-for-service to attain desired objectives, exactly of the kind that you were mentioning. Sarah, do you want to quickly go through per diem, since you mentioned per diem?
Okay.
And capitation?
So do we have per diem?
Well, maybe just to quickly do capitation, per diem, and case-based.
Can I have the clicker? Okay, so capitation, we saw that in the exercise. Do we have capitation in Armenia? We do. So for which services? Primary health care. Okay.
What is capitation again? Everybody knows? So part of this purpose of this session is that everybody understands the language of provider payment mechanism and the incentive. So capitation is per capita payment. Yeah.
Okay.
So go ahead.
And so remember Ajay was talking about it's not only how providers are paid, but how much. So what's happening here? So is it independent of volume or is it attached to volume? So does it depend on how many services? So if you have capitation are providers impaneling patients? Okay, so you're paid per provider in your list? Is that right? Okay. So is the capitation payment tied to the volume of services that the impaneled, the patients receive?
We have capitation in primary care plus performance-based financing. And in per capita mechanism, the volume itself is not considered. It does not, it ignores the volume of the services to be provided because the country decided to introduce the incentive mechanism in order to promote the preventive care, also the testing of chronic diseases management, immunization, and others.
So we can actually discuss this now. So we've skipped ahead. This is one of those non-traditional payment mechanisms where we've combined the payment with the pay for performance. So we're glad to hear that's happening in Armenia. Can you just tell us a little bit about what services, what the performance incentives are? Those lists that are reimbursed with the performance-based financing.
Well, for various years, we have had various indicators. We started from 2010, 2011, the incentive financing, and we started with 10 indicators. Those times, they were mainly related to immunization and also to some preventive care examinations. Today we have almost 26 indicators, including both preventive and care and chronic disease management, and also women-related issues. And if the providers reach those indicators, they receive additional payments. Moreover, in case of our screening examinations and screening tests, we reimburse the amounts per case. So we apply per case financing.
It sounds like this has been the good balance. So the capitation, before the capitation, were you finding that those preventive services were underutilized? And then the pay for performance has helped to increase. So then
there's a question, I think, there.
I would like just to provide some background information on how the P4 performance was introduced in Armenia. During Soviet times, in the polyclinics, the payment was district-based payment. I mean the specific number of population were assigned to specific districts and to specific physicians. Within the primary healthcare reform project, the approach was suggested to transit to enrollment-based payment, and population were provided opportunity for open enrollment. So in early 2000s, the open enrollment-based assignment were introduced in Armenia, in the beginning as a pilot project. Then, based on successful results, it was implemented nationwide. And what relates to P4 performance, specific indicators were designed, mainly preventive, relating to preventive screenings or anemia screening, immunization rate, whether the physicians have registered for chronic disease patients like ischemic heart disease, hypertension, also indicator related to early registration of pregnant women, etc. And as Yervant mentioned in the beginning, as a pilot project, only 10 indicators were selected, that gradually the list of indicators were expanded.
So that's an excellent example, and thank you, because we were going to ask you exactly about how that came about. So for the pure capitation, just for learning purposes, I think we just want to be clear. So with the pure capitation, so before that performance-based financing was introduced in Armenia, who's bearing the risk of service utilization, the financial risk? Is it the provider? Is it the purchaser? Who's bearing the risk of the cost of services? Exactly.
Yeah, so typically it's the provider in a pure capitation model, because if utilization is far greater than expected, the provider, you as a payer are protected from the financial risk because you are just paying per capita regardless of how much utilization your catchment area or your enrolled population has. So the other point here to just raise that in some capitation systems, in addition to doing performance-based capitation, you also may adjust your capitation based on the characteristics of those in your enrollment area. So do you do that in Armenia? Do you know what I mean by that? So is it fair to pay per capita to everybody? So I'm trying to think here that is the distribution of risks in the population going to be the same?
Okay, either those who are like healthy or not healthy.
Exactly. So in some country cases, they actually risk adjust the capitation. So if you have more elderly people in your catchment area, do you do something like that?
I just wanted to mention about the risk of this mechanism. As we have seen, the doctor was going after very healthy and yes, healthy, young, pretty girl, and the other part, most vulnerable part, are just out of the scope.
So that's in economic terminology, they call that cream skimming. So in order to avoid cream skimming, sometimes countries have adjusted the capitation payment so that you, as a provider, no longer have that incentive. So if you have high risk or chronic patients in your enrollment, you actually might get paid a little bit more so as to avoid those issues. Go ahead, maybe quickly go through per diem and per diem.
Okay, so per diem, do we have per diem in Armenia?
Do you use per diem as a provider payment mechanisms? Do we know what per diem is? Is everybody clear on the language, the concept? Per diem is what?
I assume that they refer to the mental care, which are reimbursed by the SHA, depending on the amount, on the quantity of patients that they provide services to. That mainly they refer to mental care. Probably it will cover also other services like palliative or rehabilitation, but it's yet being discussed. Currently, in our region, the mental dispenser reimbursement is being done through this mechanism.
You're being paid depending on the number of days you spend in the mental health facility. Is that what you're saying? Or the number of... Yeah. So quickly, who bears the financial risk in a per diem type? In hospital, for inpatient, yeah. So who bears the financial risk in this situation? Is it the payer or is it the provider? Only the payer? So it's actually a little bit complicated in this case. It's the provider bears some of the financial risk, but actually the payer also, because it's not linked to the volume, it's actually volume dependent. The payment is linked to actual utilization. So you as a payer will pay the provider more depending on if more mental health or more rehabilitation. But once you're in, right, you're just giving them a fixed payment per day. So part of that financial risk is borne by the provider and part of it is borne by the payer. So this is sort of a little bit more complex situation. Just to understand the intuition behind how that incentive might work is important.
Բայց այստեղ նույնպես global budget.
Here again, we apply the concept of global budget because the number of beds is limited.
What about for TB care? Is per diem used, or has it been used in the past for TB care treatment? Anyone?
In
case of TB care, we have both global budget, and depending on the number of beds per day, we also receive the expenditures for food, to cover food.
Do you want to go ahead with the final one? Or go ahead in terms of slides.
Okay. So the strength of the per diem payment then, low transaction cost, is it easy to administer? So there may be some incentives for efficiency because the provider really has incentives to limit the cost per patient day, right? But then the weaknesses are that there's incentives for the provider to keep the patients in longer. So we've heard in the region for TB, for example, patients stay a very long time. And maybe even if there's a cap on the per diem, then they might be admitted again. There's also continuous monitoring that's required, so that could be quite burdensome, right? So especially for these highly complex diseases that require monitoring to know if it's actually medically necessary.
So finally, let's get them to do the case-based payment. So do you want to go ahead? So what's a case-based way of paying providers?
Do we have that in Armenia?
So just to make sure everybody understands the language, let's think about the logic of the case-based payment first. What is the logic of paying by case? What really is case-based payment?
I'm not a specialist from the health sector, but as far as I understand, it depends on the number of beneficiaries, those who use the services, and so the service provider will be compensated accordingly, reimbursed accordingly.
Anybody? Are you a medical doctor? Oh, great.
But I'm just trying to guess. Maybe you pay for certain cases, you just you just create a list, you restrict the cases, and then you pay for these cases, and you basically pay for service, but for a certain cases, you just create a list of cases.
And do you have the same payment for each
No,
disease?
no, I think what he's referring to is the benefits package, right? He's saying that what gets covered are certain cases, but a case-based payment mechanism, just to explain to everybody what really is the logic behind it.
Yeah, when,
what is it?
Actually, this is when the patient is admitted, for example, to a hospital, he is getting treated, and after the dischargement, the hospital gets the payment from the government or whatever, or the insurance company.
But why do they call it case-based payment then? Why
because
not
it's
just
according
fee-for-service?
to the single case that is done already and it's finished. And
Right.
there is a fixed amount of money according to
So,
each case.
Exactly. So let's use the term a bundled amount, right? So for any case, you're given an average reimbursement. So that's what is a case-based payment. So he has not understood. Yeah. What's the difference between fee-for-service and case-based payment? Yep, go ahead.
Okay, first of all, case-based payment is the major payment mechanism which exists in Armenia for hospital services. Let's fix it. The difference is following. If under fee-for-service, if a patient was admitted, let's say, for appendectomy, the hospital would charge for each service a separate fee to the payer for sonography, for lab tests, for surgery itself, for every material even sometimes used during the surgery, okay? It would be a huge bill consisting of dozens or hundreds of lines for each thing they spend. But for under case-based payment, there is a fixed cost per appendectomy, and it provides more incentives to the provider to optimize its costs, not to spend too much.
Right. So a crude analogy, very crude, I don't think it's accurate, is if you go to eat in a restaurant and if you pay a la carte versus paying for a buffet. So here, as you know, you can think of going in and you're just paying a flat amount for regardless of how much you eat. Is crudely speaking like a case-based payment, whereas if you pay a la carte for everything that you eat is like a fee-for-service. So it's trying to make something slightly closed-ended, but not completely. So if we go through our logic here, is a case-based payment dependent on the volume of utilization? Yes, because the more people who get admitted, the more you'll get paid. Now, for every admission, is a case-based payment dependent on the volume of services used by that patient? No, you get an average payment. So that's the key difference, right? The case-based payment you don't get for every service used, right? It's a bundled payment. So it's no longer a la carte once you're admitted. So that's the key difference. So here again, it's an intermediate case where the financial risk is borne by who? Only the provider? It's both, right? Because if you're...
Because you can admit a lot of patients and get more money.
Yes.
But in cases you have complicated patients,
you may have to.
the money is not enough to treat them, so you get the risk.
The providers bear some of the financial risk. It's another situation like the per diem payment case. And you know, this is, I think, as you said, it's been applied in many, many countries. You might have heard of DRGs, diagnostic-related groups. That's a form of case-based payment. So you actually, it's a way of giving an average reimbursement so that you have an incentive, the provider has an incentive not to be efficient, basically, not to prescribe every single test or provide every single medicine, but to have some limits on that. And so it's a process by which you try to determine an average reimbursement per case, and that's what you get. So it is not dependent on what actually gets treated or what actual treatment is given. You just get an average price per case. Did you want to add something? Somebody raised their hand? No? Okay, so just making sure here that how you pay providers has elements by which you can shift risk, but also use these mechanisms in order to improve quality of outcomes or to attain other objectives of the health system. Sarah, if you can go ahead. So one point I think that was already mentioned by many, if you can go ahead in slides.
Exactly, so the incentives to reduce the number of services per case. So it's almost like a mini capitation per each service. You want to reduce the utilization. And then you can also help control costs as payment is closed-ended, right? So lots of strengths. Administratively, it can be quite complex, so it requires coding, especially DRG requires coding and so we often don't see this in lower income countries where there might not be the information and the capacity. The hospitals may also discharge prematurely, and that could also compromise quality, right? So if they're only charged on average and you have an above average cost patient, then what might happen to that patient? They might be discharged before they're ready to be discharged, so that could really affect quality. So what are some of the things you could do with this case-based payment to mitigate the challenges? Anyone want to have a crack? What could you do with the case-based payment to avoid this under provision?
I believe that we can improve this by introducing IT surveillance mechanisms.
You can have very strict guidelines. So there are many such factors that you can implement in order to be very similar to types of issues that we discussed. You can also look at what's happening to the volume of patients that are coming in, what type of services, and you may also want to adjust the rates over time. So again, maybe Sarah, we can go ahead in terms of slides. Go ahead.
Okay.
I think so basically the point here is to make sure you all understand what we mean by line item budget, what we mean by global budget, fee for service, capitation, per diem, and case-based payments. The issue here is sometimes, and it was already mentioned by some of you, that in many countries we observe that different provider payment mechanisms are used for different providers, for different levels of providers. So often we see that primary health care, outpatient services use capitation, mental health, rehabilitation will use per diem, hospital services will use a mixture of case-based and some global budget, and so on and so forth. But rarely do we see sort of a very simple standard model that's used across the health system. So there's increasing complexity, and sometimes it's not very clear how these interact. So one has to design the system carefully with the objectives in mind in terms of increasing efficiency, making sure that appropriate care is not skimped on, and that the best possible outcomes are being received. So the reality is often very complex, and sometimes you can use a mixture of these provider payment mechanisms in order to attain those outcomes. So maybe briefly, if we can do that, I think I would like to remind people that it's not just how you pay the providers, but also how much you pay providers. That's important. So many times we've seen in policy dialogue across countries, they fixate on how you're paying the providers, but of course the amount of money that you pay also matters. And so you want to have an incentive also for the providers not to pass on costs like informal payments to the patient. So it's not just how you pay providers, but also how much that matters. So if you're in a system where you're seeing a lot of informal payments and things like that, you may want to go back to assess, is it because of low levels of payment mechanisms that's causing this additional, it's kind of like a fee for service informal payment that's creating a problem in the system. So it's a way to watch out as to something being wrong, and also the levels of reimbursements that are being paid.
So I think we'll just go through this very quickly. We've already talked about the non-traditional mechanism, which is the pay for performance. And we've talked about the strengths and weaknesses of that. It can be used as part of the capitation to incentivize use of particularly preventive services or underutilized services. But then the evidence on health outcomes is weak, although new evidence is emerging that pay for performance has actually had a positive impact on health outcomes. Now, it also is an issue, sustainability could be an issue. Now, in Armenia and in the region, the pay for performance is quite different than in lower income and lower middle income countries where the pay for performance might be provided by the donor, so there's sustainability issues. But that seems to not be the case here since it's covered by the government. So it's institutionalized as part of the health payment, the health system. So this is an example from Estonia where we're just looking at kind of the impact of these provider payments on priority services. So Estonia's provider payment mechanisms are quite complex, and you can see how Ajay mentioned that often there's a mix of provider payments that are used in the system and for different providers. So you can see that here, that family physicians are paid capitation, fee for service, and pay for performance. So there's different mechanisms, maybe for different providers. And then ambulatory specialists are fee for service. So there's a whole range of mechanisms. But what I wanted to point out here is that for immunization, so the Estonian Health Insurance Fund is actually the core purchaser now for preventive and curative services. And people contribute through payroll, but the Health Insurance Fund actually reimburses through a bundle of services. So they don't just pay for the immunization visits, but actually for the full package of vaccines to be delivered to children. So they're reimbursing on that whole schedule. For HIV and TB, it used to be that those services were outside the health insurance package, and they were covered by the Ministry of Health. And drugs were also covered outside. They were paid for outside that health insurance fund. But now that that health insurance fund has more purchasing power, now it's the single purchaser, then the TB and HIV drugs are being moved into that package. So the health insurance fund will actually be providing those, will also be purchasing those. So the quality bonus system, the family doctors are actually participating in this quality bonus system, and they get preventive services reimbursed as part of their pay for performance, monitoring of patients with chronic diseases, and then professional competency. So yesterday we talked about some of the incentives and disincentives. You talked about some of the things that you're not rewarded for if you're a doctor in Armenia. I think somebody mentioned you're not rewarded for continuous quality education. Is that correct? Maybe someone over here. Are you rewarded for completion of different certifications in Armenia?
No, I don't have any suggestion, but I will add.
Okay. Yeah. No. Okay. So it sounded like, I just wanted to confirm, yesterday someone was saying you're not rewarded, but so the Estonia pay for performance scheme is actually quite complex, where they have bonuses for ensuring those preventive services are offered, but also some indicators on what providers are doing. So certain certifications, they may earn more, and they can earn 41% of their total capitation payment as a bonus. So we might think, well, what is that financially? How much does that cost? You have to think, do we have the budget to do that? And in Estonia, it's only been 2% of the total primary healthcare budget that's been used for this quality bonus system. So I think in Armenia, we've heard here that you have the same, a very similar pay for performance mechanism as Estonia. Can you tell us maybe how it differs for, let's just use the example of immunization. Is it per visit, or is there anything to ensure, say, children complete their immunization, the full immunization record, or is there, what about dropout rates? Like how do you encourage providers to ensure people are coming back for their immunization schedule?
Roman, about immunization, awarding financing depends on the entire scope of immunization according to the calendar. If they meet the scope within a specific period of time, whatever has been identified by immunization calendar, they get rewarding financing. If immunization is not performed within this calendar period of time, then they are outside of this rewarding financing. If because of some reasons they are late, but that they have performed immunization but not within a specified period of time, then the score is not counted.
I didn't realize that. So it is actually similar to Estonia then, where you're reimbursing for the full package. Okay, so is there anything else about, so the TB model, can someone tell me here how the TB, I know that I've heard from WHO that there's some attempts to change the way TB providers are paid or how providers are paid for TB. Can anyone speak about that? I know there's a big effort in the region by WHO and also supported by Global Fund.
The payment mechanisms for TB services in Armenia were changed in 2014. Before that, cases were paid on a combination of, on a basis of combination of fee per case and per diem. So it was a fixed price for treatment of each TB patient, but if for a certain duration, that if they would keep patient less than that fixed duration, they would be paid less than the case-based payment minus per diem for the difference in number of bed days. In 2014, so it was an incentive for providers to maximize the length of stay, to keep patients as much as possible, to get the maximum payment, and some patients were successfully treated during this period, and then they would catch TB again and become MDR TB patients in the hospital from other patients. So in 2014, Ministry of Health implemented the new payment mechanism for TB services, which was later also expanded to psychiatric services, so long-term care. Now they get major part of their budget as a fixed cost, regardless of the number of patients or volume of work, which covers
and which providers are we talking about here?
Huh?
Which provider are you talking
TB
about?
care providers, specialized TB hospitals.
Okay.
Hospital care for specialized, we still have this vertical Soviet system in the country for TB care, so special hospitals or specialized departments in regions somewhere. So they get about 75-80% of their annual budget on a fixed base amount, which covers their fixed cost, and about 20% are operational costs, which depends on the number of patients, and they cover only two cost items, drugs and food. So if they have less patients, this 20% may decrease. But say 80% they will get for sure. So they don't have any incentives. And the average length of stay for TB patients has drastically decreased in Armenia after implementation of this new mechanism. Hospitalization rate has decreased a lot. There were a lot of savings in TB program, which were also used within the facilities to improve the payment, for example, of their medical staff.
Okay. Excellent. And so are you doing anything differently with the ambulatory care providers, the primary care providers, and then the community services, changing the way that they're paid?
Primary healthcare providers for TB services, the physiatrists who are working in polyclinics, they are paid on a per capita basis, just like any other neurospecialists at polyclinic, at ambulatory polyclinic level. So they have their catchment area population, and for each patient they get a fixed amount of money per year to perform some functions which are fixed by the Ministry of Health, what they are supposed to do, follow-up, diagnostics, early detection, and things like that.
So Sarah, I think we're out of time, so we want to maybe take one last question.
Okay.
Microphone is not on. Ask her to speak in the microphone. I can't hear her. So this is the indicator of early detection of TB as we're talking about it. Award payment. So one of the 32 indicators is the early detection of TB cases. This is one additional indicator. About Estonia, I would like to say one more thing. Although in the primary health care we have got per capita financing for children and for adults, nevertheless we do not have differentiated financing model, something that we saw in case of Estonia, because we all know that among children under 5 we have got a half consumption of services. Among adults, among the pensioners, among the chronic diseases, we have got over and success use, but financing per capita under 18 for all age groups are the same. Above 18 up to any age group is the same. Whereas we know that actually we do not have excess use of service among the adults of working age, but we have got excess use of services among chronic disease patients, and also in children age. There are some cases when they come to visit the doctors because of preventive, but the intervention rate is different. But per capita financing for any person is the same, which in case of Estonia is strictly differentiated.
continue because the second session will go deeper. This is more an introduction to the provider payment mechanism landscape. And as we break for coffee for the next 15 minutes, I want you to think of one thing. So you're paying primary health care providers capitation, right? So isn't there an incentive for the provider to keep the population healthy? Is it or not? So I want you to think about that for coffee break. Is there an incentive because you're getting paid regardless of the utilization, right, in your catchment area? Does that make an incentive for your provider to make sure that whoever is enrolled under you is as healthy as possible so that actually they don't need to use care? So I want you to think of that while you take coffee break. Nadeem, we go for 15 minutes. That means if we can come back by 12:55, and then we'll have the second deeper dive session on a provider payment mechanism that looks specifically at the issues of non-communicable diseases. So thank you very much. Coffee break, one more session, and then lunch. The question about keeping population healthy.